Well, I'm Patrick Hu, CEO of Moffitt Cancer Center. We're here in Chicago, Illinois at ASCO 2024. I'm here with Dr. Rob Wenham, head of GYN oncology at Moffitt. So thanks so much for being here today.
Well, thank you, Dr. Hu. There's a lot that's happening this year. In fact, I took down some notes because he's taught us to be digitally minded, and so I'm keeping track of it right here. Endometrial cancer, I think what I want to highlight is the anti-TIGIT, is the anti-PD-1, and MMR-deficient endometrial cancer. They saw a 65% overall response rate, which kind of builds on the Keynote 158 data with 50% response in the similar population of metastatic endometrial cancer. Only problem is now that we have checkpoints approved for first line, we don't really know what it's going to mean in the checkpoint after checkpoint situation, which nobody really knows what exactly to do with at this moment. In cervical cancer, I thought some of the more interesting things were the anti-EGFR antibody that was added to concurrent chemoradiation therapy for locally advanced squamous cell cancers of the cervix. Now, while it didn't meet the endpoint of PFS and OS, it did have a 10% response rate difference between those who got the anti-EGFR and those who didn't. They didn't really look at EGFR expression. They estimated it to be about 80% in the population, but it may be that there's different levels of EGFR that may be relevant in the future, so I think there's more to come on this particular molecule. In terms of neoadjuvant therapy, a lot of excitement a little bit on this one study looking at taking patients that would slightly be higher than what you'd normally do a radical hysterectomy on and giving them neoadjuvant with a checkpoint inhibitor and chemotherapy. And in that group, they show 97% of patients respond and pathologic complete responses in a third of those patients. So it may be opening up the door of radical hysterectomy and neoadjuvant therapy in a new way. And it really kind of confirms a little bit of the chemotherapy we saw in Interlace, along with the A18 data of checkpoint inhibitor and the after part of it. Unfortunately, as we kind of were expecting, another trial showed that adjuvant chemotherapy after concurrent chemoradiation therapy for cervical cancer in a pelvic localized disease setting, but slightly earlier stages than we did with the Outback trial, was also a negative trial. So I think this really puts the nail in the coffin on adjuvant chemotherapy after concurrent chemoradiation therapy. Now in ovary, I thought the ChemoID presentation by Dr. Herzog was very interesting. It generated a lot of discussion. We've seen this before with things like ChemoFX and precision therapeutics. They are touting the difference here is that they're using stem cells to look at chemotherapy sensitivity. I did note that the patients who were getting treated by the ID versus physician choice were mainly getting platinum doublets, and those in physician choice were getting fairly ineffective single agent doxorubicin. So it remains to be seen whether it's the ID or maybe we just need to choose better chemotherapies as physicians. The SOC1 trial unfortunately did not support the role of interval cytoreductive surgery for ovarian cancer, but this was much different than the Desktop 3 study, which did show a survival benefit. Part of it is that this patient population had about a third of patients that switched over to surgery after the study. So when they corrected for that, it did look like there was a benefit, so I still don't believe that this gets away with our need for considering interval cytoreductive surgery in the well-selected patient. Nivo-Ipi in clear cell. So the combination had about a third of patients having a response, and that was much better than just the Nivo alone arm. Now, unfortunately, clear cell in GYN cancers, like every other cancer, is a very heterogeneous tumor type in terms of molecular characteristics. So more to be seen there, but it gives us some promise in a very difficult to treat type of ovarian cancer. The other thing that was interesting was the addition of atezolizumab to either Doxil or paclitaxel. That was a negative study, but in a subgroup, it looked like there may be preserved activity with the weekly Taxol and the bevacizumab along with the atezolizumab. So I think there's more to come. The Merck B96 trial is going to be coming out, which is going to be looking at that randomization using that backbone. So we may find out something from that as well. And I'm just going to stop there. There's more exciting things that have been going on there for GYN cancers. If you're interested, look at our blogs and stuff like that. We'll put up some data as it's coming out for you. I do want to highlight that something that we've been working on as a department, along with Sonnet Biotherapeutics, is the creation of a phase 1, phase 2 program in ovarian cancer. And this is a novel molecule. It uses a fully humanized antibody link domains that bind to albumin, much smaller than a regular antibody, has two linkers on the side. You can put basically any kind of cytokine or anything else you can think of. But we know IL-12 is a very potent stimulator of cytotoxic T cells, natural killer cells. But if you give it in just a plain fashion, it has a short PK and it's not an effective targeting strategy. So by binding it to albumin, it goes through and it gets to GP60, gets translocated across the endothelium, and then it goes into areas that have high spark, which is a soluble, secreted protein that's acidic, rich in cytosine. And it turns out breast, liver, ovary, and neurons have very high levels of this. So we can concentrate the message of IL-12 there, and in a cold melanoma model, we were actually able to show efficacy along with combination of atezolizumab. And so we're going to be starting up that expanded study using the combination of the checkpoint inhibitor with that in the near future at Moffitt, and so more to come.
Well, that's really exciting, and what a wonderful summary of all that's going on in the GYN world, as well as what we're doing novel at Moffitt Cancer Center, such as this extended half-life IL-12 plus anti-PD-L1. It's really an exciting combination. So good luck with that, and thanks so much for that summary. And it would be great if you blogged that out and posted that on.
I will absolutely do it. Thanks for the opportunity to see you again, sir.
Thank you.